plant. Thank you. And the other picture will be a toxic plant that's going to do really, really bad stuff if you eat it. So here's where you get to test if we have a zombie apocalypse tomorrow, how useful are you to your zombie apocalypse team if you're the person responsible for foraging food? I'm always going to give you a description of the edible plant first. And what I want is after I show you the photos, please enter in the chat whether you think the picture on the left or the picture on the right is the edible one. All right, here we go. So the edible plant pictured here is something that you can stuff with cheese and deep fry and is served at Italian restaurants. And the non-edible plant here is one that causes pretty severe anticholinergic toxicity as well as hallucinations. All right, so let's get some things in the chat. And which one do you want to eat? Which one's the edible one? If I could have Seth or Katrina kind of monitor and see which one's being voted for the most.
We've got a whole bunch for the right flower.
All right, well, good job. You guys passed the first test. The one on the right is the edible one. It's zucchini flower, which is absolutely edible. And actually right about now is the time where you're seeing these pop up in gardens all over the place. A lot of my neighbors have it growing outside. The plant on the left is the toxic one, which people actually ingest it intentionally. This is Jimson weed. It is ingested on purpose for its hallucinogenic effects, but it can also cause a host of other bad side effects that we are going to cover later in the lecture. All right, edible plant pictured here is something that you can eat raw and top on salads. And then the toxic plant pictured here is one that was implicated in winning a battle between Persian and Roman armies. It is a source of cardiac toxicity and the source of mad honey. Which one do you want to eat?
I've got about 10 for the left and 1, 2, 3 for the right.
Okay, all right, good job. You passed number 2. The flower on the left is nasturtium flower. For the most part, this is an orange flower, but they do come in a pink variety as well, which is pictured here, so a little trickier. The plant on the right is rhododendron. Now you can find both of these plants in California. Luckily, I think they look nothing alike. But the plant on the right, if you have bees that exclusively gather pollen from this plant and make honey with it, it can cause lethargy. Kind of people just are laid out in bed for about 24 hours or so. And rumor has it, it's how the Roman Empire won one of their battles was by poisoning their enemy with all this mad honey. All right, the edible plant here is the source of an incredibly expensive herb or spice. And the toxic plant pictured here is one that if you even eat fairly small quantities will cause a pretty excruciating, inevitable death in about 72 hours.
I have about 3 for right and 5 for left.
Okay, well, that one's closer then. Okay, so we're starting to get into it's a little difficult to tell. The flower on the left is saffron. You can see the little red threads hanging out of the flower. It takes acres of flower fields just to produce a marketable bunch of saffron. The picture on the right is known as meadow saffron, but they're not related at all. The picture on the right is actually the source of the drug colchicine, which is a microtubule inhibitor. It works in treating gout, and microtubules are what are used in your body to do all sorts of movement within cells. And if you inhibit that in toxic amounts, we don't have an antidote for it, and it essentially causes every single organ to shut down in a pretty, as far as what I've read in the literature, a pretty excruciating way. Don't eat that. The one on the right is the one that grows in gardens in the United States. Saffron doesn't just grow in gardens, so just don't eat anything that looks like this in the US. All right, the next one, this is a fan favorite. The edible plant is one that is related to our modern carrot and is found in the wild and is a source of edibles. But the toxic plant pictured here is the most common source of fatal plant ingestions in the United States. There's always a few cases every year of it. Which one do you want to eat?
Looks like most folks want to eat the one on the right.
Oh no! Okay. So this one is really tricky. And when you do plant toxicology lectures, they always show this because this is classic. The one on the left is Queen Anne's lace. Interestingly, it has those little spikes on the stem that look very uninviting. but that's actually the tip off that this is the edible plant. The root of Queen Anne's lace is also known as wild parsnip, and you can go back and forth with breeding between carrots and wild parsnip. They're basically the same thing. The plant on the right is poison hemlock. It causes all sorts of horrible things that we're going to cover in the lecture, so we're not going to go into it right now. Okay, this one is one of my favorites. The edible plant here is one that comes up in spring and is a pleasant, oniony flavored plant that is a forager's paradise. It's one of my favorite things to forage. And then the toxic one is one that causes cardiotoxicity, can cause your heart to stop if you take it in large enough quantities.
Looks like majority are going for the right again.
Okay, good job. The plant on the right is wild ramps, or wild, it's kind of like in between garlic and onions. And all of my East Coast friends, you've probably seen this in your farmer's market where it sells for a lot of money per bundle because you can't cultivate it. The plant on the left is lily of the valley, and they come up roughly around the same time. Lily of the valley has its leaves come up a little earlier than ramps, and the flowers are not up yet. So that tip off of the beautiful bunch of flowers isn't there. So you just have to know what you're doing. I don't think they look similar, but there have been some reported cases of people accidentally foraging lily of the valley instead of ramps. All right, last one. The edible plant here has the bean of the plant is becoming one of the new popular superfoods, and you can marinate them and make pickles out of them and all sorts of stuff. It's popular in Middle Eastern and Greek cuisine. And the toxic plant is one that, like many of the other ones, causes cardiotoxicity, actually pretty severe. And it was recently featured on one of my favorite guilty pleasure Viking TV shows. The royal family uses it to commit suicide. Which one do you want to eat?
Chat looks pretty divided. I see nearly equal lefts and rights.
Okay. The plant on the left is the edible one. That's lupine flower. And if you are lucky enough to live in an area where it grows in the springtime, these come up everywhere, Alaska, California, and they just blanket fields. They're very pretty. And the beans of it are edible if you boil them and prep them correctly. The plant on the right is monk's hood flower. You can see they kind of look like a little guy wearing a hat, and these cause cardiotoxicity. All right, so hopefully that gave you an idea of why it's tricky to deal with plants. And to be totally honest with you, every time I give this lecture, I have to go back and review those photos ahead of time just to make sure I'm not getting them mixed up. They are hard to tell the difference between them. And for people who are doing it all the time, it's easy. But if you're not doing it very often, you could see how people can get mixed up and accidentally ingest something that's really toxic. So again, the point of this lecture, it's not going to make you a plant expert, but it is going to give you a framework for how to address a patient that comes in with a toxic plant ingestion without having to memorize every single one of those plants or what they all do. And the basic format is the ABCs, very similar to trauma. So we're going to go through airway, breathing, circulation. D is for dextrose, E is for EKG, F is for fits or seizures. That's one a little bit of a stretch. And then we're going to talk about toxidromes, labs, and symptom control. So starting with airway, as we always do for any kind of sick patient, you always want to assess their airway first. And you can all probably recognize the plant on the left here. It's poison ivy. And then the plant on the right is poison hemlock. Poison hemlock is going to make an appearance in many of these slides because it's going to do a lot of bad stuff. But so I can imagine you're thinking, wait, who eats poison ivy? How would that affect your airway? Well, people probably aren't eating poison ivy. But something that can happen is people will take bunches of poison ivy out of their yards or gardens or public spaces and burn them. And the urushiol oil that's in the poison ivy plant that causes that reaction does aerosolize. And so if you inhale the smoke, you can get that same allergic, swelling, rash reaction in your throat and your oropharynx and your trachea. And so there have been a couple of case reports of people who have a poison ivy toxidrome in the oral pharynx and have to be intubated for symptom control because of the swelling because they can't protect their airway. Poison hemlock can affect airway because it can cause really bad seizures that in turn cause someone to lose their airway. And so if this is the case and you have a situation where plant ingestion has caused airway compromise, you're going to want to intubate them. which leads us to B for breathing. This is a picture or a painting of Socrates. And when he was condemned to death by the state, his punishment was that he had to intentionally ingest poison hemlock. And the disciples that were with him wrote down basically the entire event of his death. And one of the symptoms that they reported was an ascending paralysis, not unlike Guillain-Barré. And eventually, because of the paralysis, he lost control of his respiratory drive and his diaphragm muscles, which leads to B for breathing. So poison hemlock, in addition to the seizures, can also cause just respiratory paralysis. And so the patient is not able to breathe. For the case reports that they've had of poison hemlock poisoning that have led to this, pretty astoundingly, those folks were intubated, were in the ICU for a few days on the vent, and then eventually metabolized the poison hemlock and it was out of their system, and they were able to be extubated. So sometimes all you have to do is some airway intervention. Next is C for circulation. This is that picture of the colchicine producing flower again. If it's taken in a toxic dose, and a toxic dose is like 2 flowers, very small amount, it can cause cardiovascular collapse and cardiac arrest. And so, of course, as with any sick patient, you want to assess circulation and start ACLS or CPR when you notice that they don't have a pulse anymore. I have bad news for this one, though. If you're already down this path where you've gone into cardiovascular collapse, there probably isn't much more that you can do specifically other than just regular old ACLS. So I meant to put D for dextrose next. We'll go to EKGs. So this is kind of the fun part of the lecture. How many folks here are currently in either medical school or in some degree of medical training and have had some EKG experience? One hand. I imagine a few folks out there. Yeah, and like anyone starting out in medicine, EKGs can be pretty intimidating, but we're going to go through some ones that are just can't miss EKGs. Luckily for you, all of the weird EKG findings that plants produce are also things that other drugs produce too, and so you will probably be familiar with some of them. We're going to split this up into fast and slow, or tachycardia and bradycardia. So let's go with the fast ones first. Starting with one of the harder ones, but can anyone look at this and tell me what is weird about this EKG? And if you want to take it a step further, what kind of known drug can cause this pattern? You can think of plants as drugs. They're basically the same thing. It looks weird, right? Everyone agrees it looks funky. All right, so one brave person, what looks weird about it specifically?
You have someone in the chat who says wide QRS, someone else says tacky.
All right. Yeah, Peggy and Riley are looking at that widened QRS, absolutely. So it is a wide QRS. Anyone have any idea what drug, if you've talked about pharmacology and toxic drug ingestions, what drug is known to cause this? It's an old school drug. Not many people are on it anymore, partly because of this reason. Okay, I'm going to give you guys the answer. This is a TCA overdose, tricyclic antidepressants, which are not as popular anymore because when taken in overdose, they cause pretty severe cardiac toxicity, one of which is this widened QRS complex, which you can imagine if you stretch it out enough, you're going to start looking like some other EKGs that we're going to show in a little bit. So there are several flowers that can cause a wide QRS similar to a TCA overdose. This one is a false hellebore flower. There's also a poisonous yew flower that can cause this. You don't have to memorize the flower, just know that this looks like a TCA overdose EKG. And if you know what the antidote for a TCA overdose is, then you know what the antidote for the plant is, which is sodium bicarb. So for any widened QRS that you're seeing on your EKG, it doesn't really matter what caused it, you want to give this drug. So there's one thing that you probably already knew in the back of your heads, and now you can apply it to plants. All right, what about this one? This is what that last one was trying to become. We have
Lots of votes for torsades.
Perfect. All right. And here, that poisonous monk's hood flower that we talked about in the beginning, this flower can cause torsades, which is why it can cause death. This flower also shows up in Colorado, where I currently live, around the same time as some of the good mushroom foragings. I was very, very excited the first time I saw this growing wild. I kind of lost my mind a little bit. So anyway, it can cause torsades. And if you know what the treatment for torsades is, you know what the treatment for monk's hood flower is, which is magnesium sulfate. And push 2 grams super fast and keep pushing it until the torsades goes away. All right, what about this one?
Lots of folks chiming in VTAC in the chat.
Love it, great. And so the thing with VTAC is it really doesn't matter what causes it. Any flower that causes a cardiotoxicity could ultimately lead to VTAC, and the treatment is going to be the same just as any other VTAC of any other etiology. You're going to give amiodarone if they are stable and electricity if they are not. Stable meaning their blood pressure and their mentation. All right, now let's talk about the slow or the bradycardic things that can happen with a toxic plant ingestion. Does anyone recognize this particular EKG from something that you would have studied also with pharmacology?
Nothing in the chat this time.
Ooh, okay, we got a stumper. Does anyone see anything weird in the EKG? Even if you don't know what to call it, if you want to just like say where the weird finding is.
Ian points out lead 3. We've got wide QRS, delayed ventricular depolarization with double QRS in lead 3. Salvatore Dali mustache ST, which is a new description. I haven't heard that before.
Yeah, so the Salvador Dali mustache is exactly what we're talking about here. Do you all see that behind, can you see my mouse? Okay, behind each QRS complex, there's this swoop downward. This is known as the Salvador Dali mustache. It's really in all of the leads here, most of the leads. And this is indicative of digoxin use. I just want to clarify one thing. This does not indicate digoxin toxicity. If you get an EKG on every single person who takes digoxin for legitimate reasons, you'll probably see this finding. And it's a really fun party trick in the ER when you're like asking someone's medications in the room, and then the tech hands you the EKG and you're like, oh, do you take digoxin? And they're like, wait, how do you know that? And you're like, oh, I'm just that good. This is a pretty classic finding for it. The only times you actually have to worry about digoxin toxicity is if it's causing a slow heart rate that is now so slow that their overall cardiovascular system can't keep up with it, and they have a decreased blood pressure or decreased mentation. And you guys also probably know this, that digoxin is derived from a plant, which is this bad boy right here, the foxglove plant, which is beautiful. And because they are the same, again, you can just think of plants as drugs. And if you know and recognize this EKG as being a digoxin pattern, and you have somebody that is unstable and needs treatment, luckily the treatment is exactly the same as it is for digoxin toxicity, which is digibind, or the digoxin immune fragment. It binds all the digoxin irreversibly to help your body open some of the channels up again. So that's the cool thing about the EKGs. None of these are unique to plants. Every single one of them is something that you could recognize from pharmacology and just knowing your EKGs down cold. And the treatments are always exactly the same as they would be for any other etiology of those findings. So now let's move on to D for dextrose or glucose. Pictured here on the left is something that we don't see in the United States very often, but you can. This is the ackee fruit. It is used primarily in West African cooking cuisine. And in the ripe form, all the way on the right side of that picture, it's totally fine. But in the unripe state, which sometimes when they ship it to the United States for commercial import, they have to ship it in a less than ripe state. it can cause severe refractory hypoglycemia, AKA low blood sugar that stays pretty low. And so this is just a reminder that for any critical or sick patient, in addition to your airway, breathing, and circulation, you always want to check a sugar. This luckily is treated just the same way you treat any hypoglycemia, as you give them sugar. All right, and now we're moving on to F for fits or for seizures. So I talked about this earlier, but that's the poison hemlock plant again. And this, along with a few other plants, can cause very severe refractory seizures. With any seizures, someone who comes into the emergency department and they're actively seizing, the first thing that you do is take a big breath and don't freak out. People have seizures at home all the time, but you want to start intervening when they're lasting longer than 5 minutes, 10 minutes. Now you're starting to worry about status epilepticus and you're wanting to break the seizure. And as with all seizures, the first thing that you're going to grab is going to be a benzo. So typically lorazepam or Ativan if you have an IV, midazolam or Versed if you don't have an IV and you need to give it intramuscularly. And you give them a few times and see if they work. Now, the caveat with plants, and this is also true of any kind of toxic ingestion that causes seizures, is the next line therapy that we often reach for in the ER when someone is having a seizure would be an anti-epileptic drug or an AED. This is stuff like Keppra, fosphenytoin, phenytoin, etc. And the reason why you don't give them for a toxic ingestion or a plant ingestion is in the name itself. They're called anti-epileptic drugs. Well, this is not epileptic seizures. This is triggered by some sort of thing. So whether it's a drug overdose or a plant ingestion, those medications are not going to work for you. Now, they're not going to cause any harm. Keppra is fairly benign, but it's also not going to do anything and you're just wasting your time. So the treatment for seizures for plant ingestion or any other kind of toxic ingestion is benzo, benzo, benzo. And if you're starting to give so much benzos that you're worried about airway compromise, where the patient will no longer be able to breathe on your own because you're giving them so much, well, then you intubate them and you just keep pushing the benzos until the seizures stop. Next up is toxidromes. So we'll talk about the two major types. All right, so this patient comes in with a plant ingestion and they have little bitty pupils and they are tearing, sweating, lacrimating, all the things. They're producing lots and lots of urine. They're having lots of diarrhea. What toxidrome is this? You know this.
Bunch of people saying cholinergic in the chat.
Perfect. Exactly. So it is a cholinergic toxidrome, which is the whole sludge thing, which basically everything is just bleh, like coming out. Poison hemlock, in addition to doing all the other stuff we talked about, can also cause a cholinergic toxidrome. And the treatment for it is the same as with any cholinergic toxidrome. What you want to do is prevent the patient from drowning in their own secretions. And so you give atropine, which will dry up bronchial secretions, and you give as much as you need until the bronchial secretions are dried. It doesn't really prevent the other stuff. It just allows them to protect their airway. But if you recognize the toxidrome, then you will already know the treatment. What about this one? This one's easy. Big pupils, dry as a bone, red as a something, mad as a hatter, all the stuff.
Couple votes for anticholinergic.
Perfect, yeah. And we alluded to this earlier as well. Jimson weed, which is pictured here, is taken intentionally, recreationally for the hallucinogenic properties. But those hallucinogenic properties are part of the anticholinergic toxidrome. That's what the mad as a hatter part of that little rhyme is from. The medication that you're traditionally taught to reverse an anticholinergic toxicity is physostigmine. Really quick caveat, because I like to nerd out about this stuff. Physostigmine is a drug that works really quick on, and it also works really quick off. And it is helpful as a diagnostic tool primarily. So if you have someone, you can imagine coming into the ER, they're hallucinating, they have a fever, they are dry, they are tachycardic. Your first thought probably is not Jimson weed poisoning. It's probably, oh my gosh, they're septic. Is this meningitis? They have a fever, they're acting funny, you know? If you live or work in an area where Jimson weed is local and taken regularly. For example, I had a colleague that I met that worked in New Mexico on a reservation, and she would actually see Jimson weed toxicity from time to time. Physostigmine for her was used as a diagnostic because she could give it, and all of a sudden the patient would snap out of it and be able to have a conversation with you and be like, "Oh yeah, I took Jimson weed." Like, "Oh, okay, cool. That's the diagnosis. I don't need to do a lumbar puncture and hold this person down." And then it wears off again. So it has some risks. It can cause sudden cardiac death, and so a lot of people are kind of like, "Ugh," about using it, rightfully so. I actually had a case of anticholinergic toxicity recently, and I tried to order it for my patient that was going to the ICU, and it was on nationwide shortage, and we had to contact another hospital that was 60 miles away to courier it over to us to use it. So it's not an easy thing to get your hands on, and if you do get your hands on it, it only works for a short amount of time, but this is the textbook answer: physostigmine. Okay, next up is labs. This doesn't fit into the whole ABC thing, but like any good doctor, you're going to order some labs after you've done your initial evaluation and resuscitation. So that urine on the left looks pretty gross, right? It's really, really dark. One could even say it looks like Coca-Cola. This is a reminder that with any kind of toxic thing, especially anything where you're worried about the possibility of seizure activity, you want to check and make sure that the patient is not in rhabdomyolysis. And the way you do this is either by getting a urine and seeing if it looks dark, or by ordering a creatinine kinase and seeing if it's really, really elevated. A lot of the plants that we already covered will cause rhabdo. Another thing that you want to check, as again with any sick patient, is you want to consider getting a lactic acid. Now, traditionally, you're taught that lactic acid is produced by the body when they undergo anaerobic metabolism. You use this to evaluate your septic patients and see how they're doing. Now, most lactic acids that get ER docs pretty like hot and bothered would be 5, a 6. And then you're starting to think, wow, this patient is really, really septic, really, really sick. If you're seeing a lactic acid greater than 10, that is its own category. There are very, very few things that can cause a lactic acid that high. And one of those things that should be on your radar is kind of left field, but this is why you want to check this, but cyanide poisoning. Now, you wouldn't typically think of cyanide poisoning as coming from plants. You're thinking more about the whole house fire with industrial goods that are burning causing cyanide toxicity. But cyanide is also found in plants. And you know the adage that apple seeds have cyanide in it. Yeah, they do. It's really small levels. But there are other plants that have it in the pits at much higher levels. I'm Chinese, and I grew up eating a dessert that the American or the English translation of the name is almond tofu. It's this white, silky, kind of sweet dessert. And I always thought it was made with almonds. And I found out actually when I was preparing this lecture a couple years ago that it actually is made from apricot kernels, which are super high in cyanide. You can actually get apricot kernel powder on Amazon. So this is actually a reasonable toxicity to expect. And that cyanide toxicity can cause these sky high lactic acid levels. And if you don't look for it, you're not going to find it. Most people aren't going to present with that cherry red skin that you talk about. And if they didn't come from a house fire, it's not going to be on your radar at all. So get the lactic and then have that ping your brain and think about cyanide toxicity. And then finally, symptom control. So the vast majority of plant ingestions are not those terrible things that we just talked about. A lot of them are just going to cause GI symptoms, some agitation or hallucinations, or skin rash, right? And this is your little kids that are eating houseplants or getting poison ivy. The good news is for all of these, you already know how to treat them. If they're vomiting, you're going to give them Zofran and fluids. If they're agitated, you're going to give them some benzos and put them in a dark room and let them hang out for a little bit. And if they have a skin rash, you're going to think like a dermatologist and you're just going to give them steroids. All of this stuff is fairly straightforward and you already know how to do it. A word about poison control is that if you ever do find yourself in a situation where you have someone with a toxic plant ingestion, and let's say we have a family member who has a photo of the plant, it is really helpful. These people who staff the poison control hotline are my friends. I work really closely with a lot of the toxicologists, and they won't be offended by me saying they are complete nerds. And they will absolutely love to geek out about toxic plant ingestions with you over the phone and be very helpful about pointing you in the right direction of what labs to get and what management to do. And then also a word about activated charcoal. So anytime you learn about any kind of toxic ingestion period, there's always a statement about activated charcoal. And the way this works is if someone comes in and whatever the toxic thing is still in the stomach and hasn't been actually like absorbed by the stomach yet, activated charcoal can bind it with some caveats and neutralize any of the toxic effects. Well, here's the issue with activated charcoal. I don't know if any of you all have ever had like an activated charcoal latte or like an activated charcoal drink. It's like this fancy thing that people are trying to do, and it looks a little gray and it feels kind of edgy. That has like a sprinkle of activated charcoal in it. The real activated charcoal dosing that you give for a true toxic ingestion is 100 grams and 8 ounces of water that looks like you're just drinking tar sludge. And you can imagine if you have a patient drink this and then they get altered and start puking and start inhaling that back into their, or aspirating it into their lungs. And now you're going to go and try and intubate them. You can imagine the big, like sticky black mess that you're going to be trying to intubate through. So the word of warning with activated charcoal is only give this to people who have an intact airway and you are sure that they're not going to lose that airway. Or if they're already intubated, fine, throw in an NG tube and then just put it directly into their stomach. But those are the word of warnings for activated charcoal. Okay, so just to recap, with all toxic plant ingestions, just like any toxic ingestion or any sick patient, you want to go through an algorithm that includes airway, breathing, and circulation. You want to check a sugar, like with any sick patient, and give them back sugar if they need it. You want to check an EKG, and if they have a tachycardic rhythm that you recognize, give the antidote. So wide QRS, sodium bicarb. Torsades, you give magnesium. If they have a bradycardic rhythm and you recognize that Salvadoli mustache swoop that is classic for digoxin, you want to give Digibind. If a patient has seizure activity with a toxic plant ingestion, you want to go benzo, 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 or barbiturates, and you don't want to use any of the anti-epileptic drugs because they're not going to work. You want to consider your toxidromes like anticholinergic and cholinergic toxicities. You want to check labs, including checking a CK to look for rhabdo and a lactic acid to look at the possibility of cyanide poisoning. And then you want to do symptom control. So GI control, steroids for rashes, benzos for agitation. And again, a shout out to call poison control and talk to someone else about it. And that is it. Lots and lots of resources. Okay. Anyone have any questions?
Thank you, Dr. Derstine. That was great. If anyone has any questions, you can drop them in the chat or unmute. Oh, here's one question from Catherine. It says, is there a role for pro-emetic drugs in recently ingested toxins?
I think in general, with any toxic ingestions, in general, we're going away from pro-emetic drugs. I know they're still used in veterinary medicine, but they're not really used in human medicine very much. In all of the research that I did, I didn't find anything in favor of it. And a lot of the times they've come into the ER and they've probably already at least partially digested it. So all you're going to be doing is yakking up some fibrous stuff, but the actual toxic qualities, you're probably not going to get any benefit. So I think no, also with the risk of losing airway. That's a good question.
Thank you. The next question is, I might butcher these drug names, but how effective is cyostigmine on
I got you. Physostigmine.
Thank you.
So scopolamine is a drug used for seasickness or dizziness or nausea. I don't know. It probably would work. They both have, or scopolamine does have an anticholinergic pathway. For the most part, it's given as a patch, which is dosed out in appropriate and low doses. And the fact that it's available a lot of the times over the counter kind of indicates its safety. So I don't know that I've ever run into a case of like a scopolamine overdose that would need physostigmine, but I suppose it would work on that pathway.
Great, thank you. We had a question from Ian that asks if there's any guides or books to learn more about the this topic?
The short answer is no. If you look at the Auerbach textbook about plant ingestions, it's essentially just a list of plants that goes through talking about what each plant toxin is. And this is partly why I do this lecture, is because it is, even for me, who like is obsessed with this stuff and forages, and this is like kind of one of my niches in wilderness medicine, I fell asleep reading that chapter. So you could cobble it together by looking at that. And then there's always these tox reports, aggregate reports that are published every year, and they have case studies. If you really want to nerd out about it, probably just sitting in on tox case reviews. Most major tox groups will have a weekly case review, and there would be a lot of gems in there. I learned a lot of stuff actually from going to those lectures, but I don't know of a single source for it.
Interesting, thank you. We had Kira ask if you could walk us through a patient case that you've had, or your thought process for a patient case that you've had.
Ooh. What's actually a bummer is, even though this is of clinical interest to me, I haven't had a good plant ingestion case. I did have an anticholinergic toxicity case, though, that was very interesting. I had an older patient that came in altered, and we didn't know what the cause was initially, and did the whole septic workup, and it wasn't really revealing. Asked all the questions about infectious symptoms, and then started asking about what drugs were in the house, and what, like, both the patient's medications and other people's medications, because we were noticing some stuff that kind of fit an anticholinergic pathway. The patient had like the big pupils, and lots of other stuff was going on with it too, fever and altered. And they, part of this too is doing a really good physical exam. They had ankle clonus, which was a tip-off that something neurological was happening as well, not just sepsis. And then we eventually got a family member to verify that one of the medications they were taking was an anticholinergic drug. And that was the person I ended up sending to the ICU on, that we had to get physostigmine from another nearby hospital by using the poison control area to help, and the pharmacy to help coordinate it. But yeah, when you're giving a lecture, it's all you're thinking about is plants and toxidromes and everything. But in real life, most of the people that come into the ER are just regular old sepsis. And so when something in the patient's presentation or on their exam isn't fitting the clinical picture as you know it, you just have to remember to kind of step back and think, wait, what zebra, what other weird stuff am I kind of missing here?
Great, thank you. That's all the questions we have currently in the chat. Oh, one more just popped up. Have you used an actual plant to treat a patient? For example, you mentioned digitalis drug that is used in cardiac patients, but have you actually used a plant?
That would be super cool. So there is actually a wilderness medicine, plant medicine, like therapeutic plant medicine course. I think it's down in Arizona that I've been wanting to take. I haven't had a chance to do it yet. That talks about kind of old world medicine using plants. So this is like willow bark as aspirin type of stuff. I personally have not, because I work in a fancy pants ER that has a pharmacist and a Pyxis machine that just spits out a drug for me. That being said, the drugs that we use have been tested for dose equivalences and interactions with other medications, et cetera. The reason why I think in general in modern medicine we don't use just a straight up plant is because with each plant you can't really know what the dosage of the active component would be. And plants are complex things where they have probably multiple drugs, multiple chemicals, et cetera, in it. Whereas a pill is for the most part isolated to one specific thing where for the most part, what you're going to get from it. And so plants are these like complex kind of multi-drug delivery systems, whereas a pill is going to be exactly the thing that I want to use. So the short answer is no.
Interesting. And Sierra wanted to clarify if the course you're talking about is the Herbal Medics Academy with Sam Kaufman, or if there's another one.
I think it's a different one. Let me see if I can find it in my email real quick. I will look it up and I will email it to the group when I find it, okay?
Great, thank you. And our last question we have, is there anything you can do in the wilderness setting with ingestions other than stabilize the ABCs?
That's a good question. So it depends on what your capabilities are in the wilderness. Are you going out hiking with your buddies and your first aid kit is a Sam splint and some bandages? Or are you going as the medical provider for an expedition and you have a full med kit on you? If you don't have stuff on you, you can't check a sugar and you can't give sugar in the wilderness. But if you have a glucometer and a juice box, you could actually do something about it. So part of what you guys are doing and getting all this medical education is preparing yourself as the provider, not just with the knowledge of how to treat these things, but also, if you guys haven't had a lecture on it yet, how to prepare a med kit to be prepared for a lot of the basic and important stuff that's out there. We didn't even cover anaphylaxis and EpiPens, but that's something else that can happen with plants. And if you are a wilderness provider, you want to have one on you. When I did one of my very first wilderness med courses as a med student, they talked about how to build your first aid kit and what to put in it. And I remember one of the guys talking about how he prescribed himself EpiPens, or had his primary care doctor prescribe him some EpiPens, even though he didn't have any allergies, but just so he could have them in his kit. So things that you might want if you are going to be responsible for other folks is a glucometer to check sugars, an EpiPen. And then if you have your medical license and you're being paid or sponsored to be an expedition doc, you have benzos in your kit and you have intubating meds and tools too.
Interesting, thank you.
Mm-hmm.
We have a flurry of thank yous from our audience. Your talk was amazing. I'm backed by many by saying that. I just want to thank everyone for attending tonight. And thank you, Dr. Derstine, for lecturing with us. If you don't mind just staying after a few minutes, we'd love to quickly chat with you. But for the rest of everybody, thank you for joining us, and we'll see you next week for Movie Medicine.
Thanks, guys.